Hey Brainwaves listeners, it's Jim Sigler. For those of you who've been fans of the program since its earliest days, thanks so much for your continued interest and your support. Back in those days, back in 2016, we put out an incredibly informative show on the multidisciplinary care of patients with amyotrophic lateral sclerosis, ALS. It's been 3 years since we originally released that show, and there have been some major advancements in the care and the management of patients who suffer from this horrifying degenerative neurological condition. There have also been some major advancements in our podcast editing process in that time, so hopefully our remastered audio this week sounds a bit more tolerable. Anyway, we'll get to the big ALS clinical updates at the end of the program, but first let's play back that prior interview featuring Dr. Lauren Ellman, who is an associate professor of neurology at Pennsylvania Hospital. She's the associate director of the Penn Comprehensive ALS Center and the director of research operations for that center. Here we go. Receiving a diagnosis of amyotrophic lateral sclerosis is a devastating experience. There is no cure, and unlike many other neurodegenerative diseases affecting the nervous system, the average ALS patient only lives another 3 to 5 years after diagnosis. And in the meantime, our patients are losing strength, they're losing energy, and they're losing the ability to function independently. So instead of relying on disease-modifying pharmacotherapies to treat these patients, many of which have failed or are still being studied in clinical trials, neurologists work to deliver more comprehensive care. Here on Brainwaves this week to talk about multidisciplinary care in ALS patients, I've got Dr. Lauren Ellman, Associate Director of the Penn Comprehensive ALS Center at the University of Pennsylvania. Thanks for being on the show today, Dr. Ellman.
Thanks for having me. I'm glad to be here.
Let's start with a description of your ALS multidisciplinary clinic. When a patient comes to see you, what happens?
Well, when patients come to see us, they either find us on their own because they think they may have ALS, or more often they're referred in by outside neurologists. Usually, the referring neurologist knows that the patient has ALS, but they often haven't told the patient that because ALS is a very difficult diagnosis to discuss with patients. Referring doctors often describe the disease to patients as motor neuron disease. So one of the things that can be very confusing to patients is that ALS goes by a couple of names that mean the same thing: motor neuron disease, ALS, and Lou Gehrig's disease. So when I first see a patient, the first thing I ask them is, "So what brings you here today? Why are you here to see me?" And that gives me an idea of where they're coming from, what they know already. And the most common answer I receive is, "My doctor doesn't know what's wrong with me."
Do you think that's because doctors don't know how to have that conversation initially, or because they actually don't know what's going on?
I think most of the time the referring doctor knows exactly what's going on. It turns out that the diagnosis of ALS is not very hard to make. Usually the doctor...
I guess I should jump in here and explain how ALS is diagnosed, which, like Dr. Ellman said, does not have to be that challenging for a neurologist. But it is a little more nuanced than, say, diagnosing Guillain-Barré or something. The revised 2015 El-Escorial criteria, which was developed by the World Federation Neurology Research Group, involves the exclusion of all other causes of symptoms that could mimic ALS. ALS, therefore, is a diagnosis of exclusion. Symptoms of ALS must also be progressive, and a diagnosis of ALS requires at least one of the following. First, symptoms of upper and lower motor neuron deficits in one limb, or second, lower motor neuron deficits in one region on clinical exam, or 2 regions by EMG. This revision has expanded the diagnosis of ALS to include what would have only been possible ALS, according to that first El-Escorial criteria. And one thing that we can all learn from this change is that the presentation of ALS is variable.
About 2/3 of patients present with limb onset disease, which means that they will have weakness in one arm or one leg. The other 1/3 of patients will present with bulbar onset disease, and that is most commonly experienced as a change in speech.
I should also mention a separate set of criteria which have been proposed, and some groups use, the Awaji criteria. Similar to the revised El-Escorial criteria, the symptoms must be progressive, and other conditions must be excluded. To meet the Awaji criteria, an ALS patient must have upper motor neuron signs on clinical assessment and lower motor neuron signs by clinical, electrophysiologic, or histopathologic assessment. These must involve the bulbar region and at least 2 spinal regions, or they must involve at least 3 spinal regions. When the 2 criteria, the Awaji and the El-Escorial criteria, have been compared head-to-head. Each has very similar specificity, about 99%. But the Awaji criteria generally have been found to be slightly more sensitive, although the sensitivity for this is pretty low, 50 to 60%. All right, now that we know how to diagnose ALS, let's return to Dr. Elman's clinic.
Sure. So at our clinic, and this is the pattern at most multidisciplinary clinics, we have quite a large team to help take care of people. So one of the things that I tell people during that conversation about breaking the news is that there will be a team to help them through the disease. And that team consists of their physician, which is me in this case, a nurse practitioner, a research nurse coordinator. We have social work available. We also have a physical therapist, an occupational therapist, a speech and language pathologist, and a dietitian. So all of these people together help take care of the patient with ALS and the caregiver as well. So not every patient sees every member of the team. It depends entirely on what the needs are. Every time the patient comes to clinic, they see their physician. We always check their weight. We always check their forced vital capacity. And depending on what their needs are, they may see physical therapy and occupational therapy. They may see speech and language pathology.
As you can tell, these visits can be pretty long, and patients receive a lot of care during this time. Sometimes visits are just as short as 45 minutes if the patient's stable, and sometimes they can last several hours. And while there is little research to support the implementation of the multidisciplinary clinic for ALS, mostly retrospective papers and anecdotal reports, it's practically a gold standard in the care for these patients. At this point, we'll start to focus on some of the more specific aspects and how this clinic addresses the major issues faced by ALS patients, starting with how you should break the news of the diagnosis.
It's very important to break the news about the diagnosis carefully to a patient, and this has to be done in a fairly specific manner. Once I've established a diagnosis in my own mind, I usually ask the patient, is it okay if we talk about what's going on right now? And they always say yes. Patients come wanting to know what's going on. So then we talk about the diagnosis, establish that the diagnosis is in fact ALS. And at that point, we start talking aggressively about symptom management. And that's very specific to individuals. Dysphagia is a fairly difficult symptom to manage. Dysphagia rears its ugly head in a couple of ways. One way is with respect to secretion management, and one way is with respect to nutrition management. It's important to know that secretions come in two flavors. That's probably not the best word to choose when you're thinking about secretions, but it serves a purpose. The secretions that are in the front of your mouth are the liquid, thin secretions that you consider saliva. There's a second set of secretions that are in the posterior pharynx, and those are thicker, more mucus-like secretions. The management of these two types of secretions is different, and sometimes the management of these two types of secretions is actually in conflict. The thin type of secretions in the front of the mouth can be managed by anticholinergic medications. My personal favorites include Robenal, Levsin. You can also use atropine drops, scopolamine patch.
If you've never managed a patient with ALS, it may seem a bit unusual to have to worry about secretion management. But the fact of the matter is, the average adult produces 1 to 2 liters of saliva per day. And when you have bulbar weakness, swallowing that 1 to 2 liters can be a real problem. The submandibular glands, although smaller than the parotids, contribute a majority of the continuously produced saliva throughout the day, about 65%. Whereas the parotid glands produce the majority of saliva during meals, and submandibular glands become less important. So we use anticholinergics like scopolamine patches or atropine drops as long as the patient can tolerate these side effects.
If those medications don't work, we sometimes inject Botox into the salivary glands, and usually that's into the parotid glands and the submandibular glands.
But like anticholinergic agents, you have to consider the side effects of botulinum toxin injections as well.
You worry a little bit about a field effect with Botox injection, so there's a theoretical risk of worsening swallowing function. Now, the thicker secretions in the back of the throat respond to different treatments, and in fact, one of the problems with all of those drying agents that I just mentioned is that if you dry out too excessively, then you risk increasing the thickness of the secretions in the back of the throat. So that's definitely something to watch out for. Now, if someone's having trouble with the thick secretions in the back of the throat, one thing you want to make sure is that they're adequately hydrated, because if people are dehydrated, they will certainly have thicker, gooier secretions in the back of the throat. The other way to treat the mucus-like secretions is with guaifenesin, nebulized medications, albuterol and acetylcysteine, nebulized saline, and again, suction can be helpful. With respect to nutrition, if a patient has severe dysphagia and profound weight loss, we discuss with our patients feeding tube placement. In our hands, about 80% of the people in our clinic with whom we discuss feeding tube placement do elect to have a feeding tube placed.
The multidisciplinary clinics for ALS patients, like the one that Dr. Ellman operates, they've been associated with more aggressive life-supporting interventions for patients who suffer from motor neuron disease. And this shouldn't at all surprise you. Compared to standard neurology clinics, multidisciplinary ALS clinics are more likely to have their patients undergo gastrostomy tube placement, non-invasive ventilation using devices like BiPAP, which we'll talk about in a minute, and they also more frequently prescribe Riluzole, which had previously been the only disease-modifying therapy in ALS. While it seems like a simple intervention, non-invasive mechanical ventilation is not routinely prescribed, although it is known to prolong life in patients with ALS by almost 2 months. One resource that's not as frequently utilized among patients seen in multidisciplinary clinics is the hospital. ALS patients just aren't admitted to the hospital if they attend a multidisciplinary clinic, and even so, they are known to survive longer than patients who are followed in the community.
I was surprised to see how infrequently gastrostomy tubes are placed and tracheostomy tubes are placed on a nationwide basis.
We have felt through experience that our patients have an improvement in quality of life. I cannot point to data on this. I will say that as dysphagia progresses, a lot of the things that patients tell us is that meals start to take a lot longer. They experience choking. They become dehydrated because thin liquids are the hardest things to swallow. And along with dehydration comes the dreaded constipation, which becomes a real issue for patients. In addition, weight loss will accelerate weakness. So what tends to happen is that patients spend a large part of their day trying to get adequate nutrition, and it becomes a real issue between patients and caregivers. The feeding tube offers a way out of this, and we present it as a quality of life improvement. As you probably know, the two life-threatening issues in ALS are swallowing issues and breathing issues. So we've discussed at some length how we manage swallowing issues. Breathing issues are followed chronically in the multidisciplinary clinic by checking a forced vital capacity, which we do routinely every time a patient comes in. The recommendations are that if the forced vital capacity goes below 50% predicted, that we institute non-invasive positive pressure ventilation.
These would be devices like CPAP and BiPAP, and often the patients will first begin to need using these devices at night when their respiratory drive is sluggish.
As symptoms progress, people may transition to using it during the day. So when someone starts using BiPAP during the day and is using it more and more, we do start talking to them about advanced directives and what their choices will be going forward. For better or for worse, people do have to make a choice about whether they want to progress to use permanent invasive ventilation, having a tracheostomy and being permanently connected to a ventilator, or utilizing hospice care. A very small minority of people in the United States choose to be on a permanent ventilator. It's less than 5%. There are many reasons that people do and do not choose to be on a permanent ventilator. It's a very personal decision. In this country, a lot of those factors are financial, to be quite honest, because most insurance companies do not pay for the nursing care required. They pay for the equipment itself, but not the nursing care. For people who do decide that they want to live on a permanent ventilator, the timing of tracheostomy is largely determined by how BiPAP dependent they are. For people who choose not to be on a permanent ventilator, as the disease progresses, we start talking to them about palliative care options and hospice care.
These are very clearly big decisions to make, and a lot of anxiety and despair rests on the shoulders of patients and their caregivers, so it's important that the neurologist address these symptoms of ALS as well.
How do you and your nurse practitioner help manage these symptoms of fatigue and anxiety and depression?
I ask about those symptoms every time someone visits. So I think that depression often happens actually quite early on. It often happens around the time of diagnosis. There's a grieving process that seems to occur. And grief, of course, is normal, and it's a normal reaction. The problem is when grief becomes pathological because it goes on too long. And as we know, pathological grief is a form of depression. The reason that I believe grief often becomes pathological in ALS is because people are forced to grieve over and over again. So they grieve at the time of diagnosis, but really they're okay. They're still walking, everything's okay. But then a couple months later, they really can't walk properly and they need a cane. And now they grieve over the fact that they have to use a cane. And then a couple months later, both legs are weak, and now they really need a walker to walk. So now they're grieving over the fact that they need a walker, and so on and so forth. But the point is that there are these repeated episodes of grief, so they never recover from their grief, and the grief becomes pathological and it turns into depression. And at that point, it really does need to be treated. So we treat early and often. Usually it takes a couple of visits before individuals will acknowledge that in fact this is a problem, because most of the time they say, I'll get over it, and then there's a realization that in fact they won't. But I will say this, the type of depression that people with ALS get is quite amenable to treatment. Anxiety, of course, is a little bit different. They get anxious because they have a deadly disease. They also get anxious related to their symptoms of shortness of breath. There are two ways to address anxiety. You can address it with a daily medication and you can address it with a PRN medication. Patients with ALS really need these PRN medications. So this is not the population of patients to be afraid to prescribe medications to. You must respect that they have symptoms, some of which are organic because of shortness of breath, but really need to be treated because that can feed into itself and people get extraordinarily uncomfortable.
So that was anxiety and depression. But then there's also fatigue. And the fatigue that's experienced by a patient with ALS is much different from the fatigue that an otherwise healthy person might experience. And you have to consider this when treating these patients.
Fatigue is an extraordinarily difficult symptom to manage. We do talk a lot about energy conservation. One of the questions that comes up all the time is they ask about exercise and physical therapy and what should they be doing.
We're going to start off on the bike. And Kristen, you're just going to be
It is unfortunately so frustrating for patients to watch themselves getting weak, and they want to exercise their way out of the disease. They want to do physical therapy. They want to get stronger. And unfortunately, our best advice actually is not to do aggressive physical therapy. The way I explain it to patients is that this is a nerve disease and that exercise does not cure nerves. That's oversimplified, of course. What we know is that if you have a muscle that's tired and you exercise it, it will get more tired. So if you think about that you just went running and your legs are tired and you sit down and you rest, then your legs have more energy and maybe you can get up and walk some more. It's the same kind of thing when a muscle is weak. If you rest it, it feels better.
Here you might be asking yourself, if exercise does not cure nerve disease, or if it only makes patients more tired, then why should we recommend physical and occupational therapy for patients with ALS? Why are PT and OT evals part of the multidisciplinary care that providers like Dr. Ellman and others offer at their comprehensive ALS centers? Well, a couple of reasons. First, it's not exactly that all exercise is bad. Submaximal exertion is good for maintaining muscle bulk and muscle tone, as we'll talk about later in an upcoming program on Pompe disease. Second, there are plenty of other advantages of physical therapy besides strength training. Dr. Ellman again.
Let me explain what PT and OT do during these visits. So these are not exercises that patients are put through. These are education sessions about proper transfers, a lot of education about stretching. Stretching is very important. So this is an example where an ounce of prevention is worth a pound of cure. One big problem people have is getting a frozen shoulder because the shoulder isn't moved through its range of motion, and then that becomes painful. So everybody says that ALS is not a painful disease, and in and of itself it's not, but you can have pain as a consequence of immobility. We figure out when, for example, people need to have a power wheelchair. We set that up. We talk about foot braces. All of these kinds of things we consider PT and OT.
Up until this point, Dr. Ellman and I have discussed the treatment of ALS symptoms using a multidisciplinary approach. Pharmacotherapies for pain relief, anxiety, secretion management, botulinum toxin injection, nutritional support, exercise, positive pressure ventilation. But when you see a patient with a chronic neurodegenerative disease, where the median survival following symptom onset is only 3 to 5 years, you also have to consider what will those final months of life be like for this patient. And having that conversation is sobering.
It's not an easy discussion to start. I usually say something like, so it seems as if there's been a progression in your symptoms. Have you given any thought to what would happen if there came a time when the BiPAP was not sufficient to support your breathing? And sometimes they say yes, they have thought about it. But quite frequently, people say no, they have not thought about it. And depending on how they answer is how I proceed. And often it will be with a bit of education, and I will introduce basically the two options, which are proceeding to non-invasive ventilation, tracheostomy with ventilator, or hospice care. And infrequently are people able to sort of say, well, this is what I want to do. Oftentimes, they need to go home, think about it, talk about it with loved ones, and we talk about it the next time. So this brings up the importance of not waiting until a crisis situation to bring this up. And I usually try to mention that. The reason I'm bringing it up now is because we're not in a crisis situation, and it's much, much easier to talk about this when it's not a crisis. And then, to be honest, hospice can be extraordinarily helpful, because once you have helped the family make this decision, then when you believe as the physician that it's appropriate, and just to be clear, that is when you believe that there's roughly a 6-month life expectancy, then it's time to institute hospice care.
What I'll jump in here and say is, and I think this is very important, it's that providers like Dr. Ellman, when they transition an ALS patient to hospice care, they don't stop seeing the patient and their caregivers.
I remain the hospice ordering physician,
responsible for prescribing morphine or lorazepam or nursing care. And Dr. Ellman remains part of that discussion with the family during this tragic transition in life.
We partner with hospice to very, very aggressively treat symptoms, keep the patient comfortable, avoid...
After having been involved in the patient's care from the beginning and helping them all along the way, Dr. Ellman and others like her will continue to support the patient and their caregivers until medical care is no longer required.
Patients have a fear of suffocation and choking, and I tell them that it won't happen because it doesn't. Morphine prevents those symptoms. Morphine is the best medication for shortness of breath and so-called air hunger. You know, on a positive note, we hear from our caregivers that the deaths are peaceful.
Lauren Ellman. Dr. Ellman is an associate professor of neurology at Pennsylvania Hospital, the director of research operations, and the associate director of clinical care at the Penn Comprehensive ALS Center. And that was our show from 2016.
Thanks so much for being on the show.
It was my pleasure.
To give you an update on the management of ALS since we originally aired this program, I'd like to talk about a couple of things. First, as of 2016, there was only one FDA-approved disease-modifying therapy for ALS, Ravulizole. It was the only specific treatment for slowing the progression of ALS since its original approval by the FDA in 1995. In May of 2017, the FDA approved the second therapy for the specific treatment of ALS, edaravone.
The Food and Drug Administration on Friday cleared a treatment for fatal neurological disorder ALS, marking the first such U.S. regulatory approval in more than 2 decades.
Edaravone, which is an IV infusion whose efficacy has been demonstrated in several Japanese phase 3 clinical trials, targets the free radicals that are generated by and contribute to progression of motor neuron disease.
After 6 months of treatment with edaravone on top of standard of care, data showed the intravenous drug reduced the rate of functional decline in patients by about a third.
While edaravone has previously not been shown to be any better than placebo in earlier human trials, more stringent patient selection and treatment of clinically definite ALS may have explained the benefit of this free radical scavenger in recent studies. According to a meta-analysis of the 3 published randomized clinical trials studying edaravone, the use of this medication is associated with a significant and clinically meaningful improvement in the ALS functional rating scale by 24 weeks. Unfortunately, the benefit of this is greatest in patients with clinically definite ALS, and experts estimate that only 7% of ALS patients who meet these specific criteria are likely to benefit from this disease-modifying therapy. In addition to edaravone, we've also studied the benefits of mexiletine, which was originally marketed as an antiarrhythmic because of its sodium channel blocking properties. In patients with ALS, mexiletine has a remarkable effect at reducing muscle cramps and in relieving muscle stiffness in patients with myotonic disorders. And there have been a few small trials to corroborate the benefits of mexiletine in ALS since 2016. You can find a couple of these references in our show notes. While more and more patients are receiving these disease-modifying therapies like edaravone in addition to riluzole and drugs like mexiletine and the multidisciplinary care that we've already talked about, other pharmacologic agents have not seen as much success in clinical trials. In 2017, a monoclonal antibody that was directed against the neurite outgrowth inhibitor A, Nogo A, was shown in one phase 2 trial to have no clinical efficacy in humans with ALS. Rasagiline, the MAOB inhibitor, has also been found repeatedly to have no protective effect. Tirasemtiv, a fast skeletal muscle troponin activator, heat shock protein modulators, fingolimod. So far, many of these treatments have not panned out in our ALS population. That said, we still have many other drugs in the pipeline for treating ALS, including adenoviral vectors, stem cell therapy, antisense oligonucleotides, which can silence several toxic gene products that are incriminated in ALS, mRNAs like SOD1 and C9orf72. We have pyrimethamine, which can lower SOD1 levels in the CSF, and many others. So stay tuned for them. That concludes our program for Brainwaves this week. Thanks so much for joining us. For more information on what was discussed today, please take a look at the references in our show notes, or you can get updates by following us on Twitter at Brainwaves Audio or on Facebook. This episode was produced by myself, Jim Siegler. Special thanks to Dr. Lauren Ellman for joining us back in 2016 when the show was originally produced. Coming up on the podcast, we've got shows centered entirely around the neurologic patient's perspective, with particular attention to the symptoms that they've coped with for years, the social implications of their disease, the stigma, and obviously their clinical course and considerations for management. Music for this week's episode was courtesy of Chris Zabriskie, Nuno Adelaida, and Maiden. Sound effects by Mike Koenig and Daniel Simeon. I'm Jim Siegler for Brainwaves. Talk to you soon.